Good morning and welcome to the Department of Medicine Grand Rounds. Our speaker today is Dr. Andrew Kapoor. Andrew is known to many of us. He's an assistant professor at the Department of Medicine, Division of Infectious Diseases here at McMaster University. He completed his medical training at the University of Toronto and went to complete his internal medicine residency here with us at McMaster, followed by HIV and infectious diseases fellowships at Harvard. He has master's degree in medical sciences from the University of Toronto and MPH from Harvard Chan School of Public Health. His research and clinical work is focused on HIV, global health, and general ID. Andrew is going to talk to us about what's hot in ID. I mean, every time I'm on service and Andrew is on consult, he teaches me something new, so I'm sure I'm going to learn a lot today. So Andrew, without further ado, it's all yours.
Awesome. Thanks so much for the introduction, Colin. Great to be with you guys today. So I was trying to think about what might be the most useful topic to talk about in rounds. And I was just at one of the major ID conferences in Washington a couple of weeks ago, and I always enjoy these talks on kind of what's hot in different areas. So I thought I would format it in that light. So hopefully you guys find it useful. I tried to pick topics that would be sort of applicable more to the general ID space, but also things that I think are kind of important or new that are coming that might impact the way people envision or see their future practice. So first disclosure is this is not a COVID talk. I'm going to touch on one aspect of COVID related illness, but I'm not specifically going to talk about COVID. And obviously, you know, when you think about what's hot in ID, this is kind of the picture a lot of infectious disease doctors are envisioning, because that's basically all we've been talking about for the past 3 years. But I think to that end, a lot of things have kind of slipped past people because there's been a lot of non-COVID research that's come out, many of it which is relatively practice changing, that's kind of not been picked up because we've just been so distracted. So that's sort of the other bent of this talk. I wanted to try and focus on some of those other things. So here's the objectives for the talk. I just want to review a few key clinical areas of ID clinical practice where important updates have occurred. These are the main focus areas that we'll talk about. One is pneumonia, second is C. diff, third monkeypox, HIV, and then we'll talk a little bit about Staph aureus bacteremia. And along with that, some upcoming research trials planned at HHS and St. Joe's. So we'll go right ahead and start with pneumonia. You know, this is an age-old problem, and you think, geez, what could be new in pneumonia? But I wanted to kind of start with, and this is the only part that we're going to talk about COVID, by the way. So I wanted to start this by talking about something that comes up very often. I was just on medicine, and this came up multiple times on the week that I was on medicine, and that is, you know, what's the role of antibiotics in the setting of COVID pneumonia, and how often do patients with COVID-19 actually have concomitant bacterial pneumonia? And this question actually has pretty deep roots. And this is a quite old paper, maybe perhaps not that old, published in 2008 by Tony Fauci. And this paper, it was a very interesting study, and it informs the pneumonia guidelines even today. And what they did in 2008 is they were wondering, and Tony Fauci has been interested in pandemics his whole career, but they were wondering, you know, when you have a pandemic influenza at the time, which is what they were thinking about, how much of those patients really are dying from their influenza and how many of them are dying from other things. And the main other thing they were worried about was bacterial pneumonia. And what they did was really interesting. And because they were at the NIH, they could actually get access to all kinds of interesting samples. So across the US at military bases, they had kept samples from people who died from the 1918 influenza, pandemic influenza, the Spanish flu. And what they did was they were able to dig up a whole bunch of these autopsy samples and basically look at what happened to these people from a tissue perspective in their lungs. And so this is kind of like the greatest natural history study, right? At that time, it was a pre-antibiotic era. So none of them got antibiotics and none of them got any kind of treatment. They died, and then they took a piece of their lung and saved it. And Tony Fauci and his colleagues went back to look at what they found. And essentially what they found was that a vast majority of those deaths that were from pandemic influenza, or thought to be from pandemic influenza at the time, had evidence of bacterial pneumonia. And so they probably died from bacterial superinfection rather than the influenza virus itself. And so their kind of conclusion from that was that about 30% of people who have influenza actually die from bacterial pneumonia, and that the sort of kind of disproportionate deaths that they saw from the Spanish flu may have actually been because people were just dying from pneumonia and superinfection in that setting. And they were then interested in well, how is that interaction between a viral infection and then the development of pneumonia happening, and what's the interplay between those two pathogens? And what I'm showing you here is actually a snippet from the most updated guidelines for pneumonia. And this is buried in the guidelines, and many of you may not know that it's there, but it says in adults with CAP who test positive for influenza, which we're starting to see thankfully now, again, should the treatment regimen include antibiotic therapy? And the recommendation is that we recommend standard antibacterial treatment be initially prescribed for everyone who comes in with radiographic evidence of CAP and tests positive for influenza. And it's a strong recommendation. And I think this is probably not in clinical practice what we do, thankfully, actually. But that recommendation actually comes from that paper. And this is in the 2019 guidelines, by the way, that these are very recent. So that hasn't changed. And the reason why I'm telling you all of this is because this was all extrapolated to COVID-19. And so a vast majority of patients, about 80 to 90% of patients, when you look at sort of some of the recent studies, patients coming in with COVID-19 are treated with antibacterial agents. And the question is that the right thing to do? This is a study I wanted to show you because it's one of the largest prospective observational studies looking at this problem. And it's probably one of the best conducted studies looking at this problem. This study was done in Chicago. It's a prospective observational study looking at patients who came in basically with severe CAP and ended up getting ventilated and had a BAL within 48 hours of admission. The BAL was done or had to be done prior to the initiation of antibiotics. And so they enrolled about nearly 200 patients with COVID-19 disease. And they were looking at the endpoint of bacterial superinfection or bacterial infection in that setting. And here's what they found. 133 of those patients basically underwent early BAL prior to antibiotics. So not everybody for probably clinical care reasons or logistical reasons that was enrolled got an early BAL and did not get antibiotics before that 48-hour mark, and that was pretty strict. But of those patients, about 21% had a documented bacterial superinfection. So these are the sickest patients, right? These are the critically ill patients. So 21%, but not 80 or 90%. And that's the sort of rate of antibiotic use that was going on at the time. And the other interesting thing that they found is these patients had both a BAL with culture, and they use this thing called a biofire panel for pneumonia, which is a PCR multiplex for 33 pathogens. And so they were able to very sensitively try and figure out if they did have pneumonia, what was the pathogen. And the point of showing you this is that it's actually not the pathogens that cause, or that we talk to the residents and the medical students about, causing community-acquired pneumonia. The majority was Staph aureus and non-pneumococcal streptococci, right? So not the typical, there's some of the, mix of the typical pathogens you can see in there, Moraxella, etc. But there's a bunch of, and Haemophilus, but the vast majority were sort of pathogens you think being associated a little bit more with HAP. So I think that's important, because the thing you'll see missing largely here is really atypicals. There's not really many atypicals here. So I think that's an important point. The second thing that they did, which was interesting, is that they basically characterized the biochemical profile, both of the serum and the BAL fluid, looking to see if there was any difference between those patients who came in with superinfection with a bacterial pathogen and those who came in just with COVID-19. And if you look here, we don't have to go line by line through this, but there's no difference, even including things like procalcitonin, which we don't use here, but is a discriminatory biomarker that, in some cases can help you determine between viral and bacterial cause, and BAL neutrophils, which sometimes can be used to suggest a bacterial, sort of more of a bacterial cause. So there's really no difference. So most of these patients don't have pneumonia. The people who come in who do have pneumonia probably don't have the typical CAP pathogens, even though they sort of fit that definition of CAP. And there really isn't any way to distinguish between them from a biochemical profile in terms of who might be sick from their COVID and who might be sick from bacterial superinfection. So since that study's been done, there have been many, many other sort of mostly retrospective observational studies that have looked at this as well. And colleagues of ours from Toronto had tried to pull these all together and try and come up with something more sort of overarching to try and help us conceptualize, how many patients really are coming in with this problem, and what about the people who are not that sick? How many of those patients have bacterial infection? Should we be giving antibiotics at the door? And this meta-analysis basically showed similar findings. It basically also kind of emphasized the point that if you're sick, the rate of bacterial co-infection is probably higher. So they call this secondary infection, but it's very difficult to determine what's secondary and what's primary, because it really depends on the sequence of events and when the testing or sampling was done after you came in. But essentially, they said only about 3.5% of people come with co-infection on presentation, and about 6.9% overall of patients who have COVID-19 pneumonia have bacterial superinfection at any point. So that's pretty low. I think when you parse it out, the sicker patients probably have a slightly higher risk. The patients who are on the ward have a much lower risk, probably closer to that 3 to 5% range. But still, that people are prescribing antibiotics at a tremendous rate, and this is still probably a little less than early on in the pandemic, but still pretty high at about 70%. So I think the long story short here is, I don't think most, if not the vast majority of patients who come in with COVID-19 pneumonia need antibiotics at all. I think the patients who are sicker probably need a little bit more of a careful consideration about whether you give them antibiotics. And in that setting, think about the pathogens, right? A little bit different than typical CAP pathogens. And you probably do not need atypical coverage as documented by many of these previous studies. And I think in those studies that I just showed you, the other thing that most of those studies do to determine whether a patient needs antibiotics or not, or whether there's not antibiotics, whether there's co-infection or not, is some kind of respiratory sampling. And in that same vein, this study I thought I would show you was just published a month or so ago in JAMA, was very interesting. And it's a study looking at the effect of a Gram-stain guided approach to antibiotic therapy in patients that are critically ill who have VAP. This was called GRACE VAP. All these trials have kind of some kind of catchy name. So the GRACE VAP trial basically enrolled patients who were over the age of 15 that were diagnosed with ventilator-associated pneumonia. They had about 200 and so patients, most or a slight majority were male, and the average age was about 70. So this is kind of bread and butter patient in a medical ICU, people that we see all the time in our ICUs across the city here. And this study was actually done in Japan. It was open label, and it was a non-inferiority study, but it was randomized, looking at these two arms of treatment. One was a restrictive Gram-stain guided approach to antibiotics, meaning we sample your respiratory tract, and if you have a GPC, then instead of the empiric guideline-based antibiotic therapy, which you might have been started on, we would quickly tailor your therapy to the GPC. So we drop off the anti-pseudomonal coverage. So for example, if you come in empirically for VAP, maybe you get Piptazo Vanco, we sample your respiratory tract, we find you have a GPC, we drop the anti-pseudomonal coverage off. Conversely, with a Gram-negative, we could drop off the MRSA coverage or the extended Gram-positive coverage. That was versus guideline-based therapy, just following the guidelines with an anti-pseudomonal MRSA agent plus an anti-pseudomonal agent for VAP. And what they found was that I'll just flip over here. The clinical response rates between the two groups was non-inferior. So you can see the risk difference there is 0.05 or 5%, was non-significant. So it showed that the gram stain guided group was non-inferior. That approach was non-inferior to just, one size fits all, follow the guidelines type of approach, which is pretty interesting. If you look at the 28-day mortality, that was not statistically significantly different, although it trended a little bit maybe towards the improved mortality of the gram stain guided group. 28-day ICU ventilator-free days comparable as well. And then this is kind of what we're here for, right? Is were we right? How close to being right were we? And again, between the two groups, no different. Slightly numerically different there, 86.4% for the gram stain guided group, 92% for the guideline-based group, but not statistically different. And the remarkable sort of side benefit of this is seen on the far right here, right? So gram stain guided group had 30% less anti-pseudomonal use and almost 40% less use of an anti-MRSA agent. So that's pretty tremendous from a stewardship perspective and from a sort of antibiotic tonnage use perspective. So I think this trial is pretty interesting. This obviously is not the standard practice, and this isn't the standard practice at our hospitals, but I think this is something really interesting to think about, both from a COVID-19 perspective, but also from a sort of general pneumonia perspective, in terms of helping us use antibiotics a little bit more precisely. So I think the takeaway messages for you from those couple of studies is that the frequency of pneumonia in non-intubated patients is likely not knowable, to be honest, because we don't sample the vast majority of those patients, but it is very low. And it's maybe, and a very conservative estimate, 6 to 8%. Some people probably argue and say it's maybe closer to 5%. It's slightly higher in ICU patients. So I think in those critically ill patients, it's something to think about a little bit more carefully. But in patients who are on the ward, I don't really think, unless you're really convinced that there's bacterial superinfection, in which case you may pursue respiratory sampling, that you need antibiotics. There's no biomarkers to help us predict that. The white count's not going to help you. Nothing that you look at in their blood work is really going to help you determine that, despite what we think. And a BAL-based approach or respiratory sampling-based approach is probably the best approach in terms of helping us use the antibiotics either more precisely or less often. And that's sort of what that second trial shows. All right, so let's move on to C. diff. I just wanted to spend a few minutes talking about C. diff because as many of you may know or maybe not know, because these kind of slipped out in the middle of the pandemic, the IDSA, which is the main guideline producing body of the Infectious Disease Society of America, which most of the world, less Europe, probably subscribe to. They produced a focus update in 2021 on C. diff, and this was really to address this major issue of the use of fidaxomicin and another drug called bezlotuximab for the treatment of C. diff infection. This is really a summary of what's in the guidelines, but I think in the guidelines previous to that focused update, fidaxomicin was listed as a possible agent that could be used for patients who had multiple recurrences of C. diff. And it hasn't been widely available and used in Canada. It's always been touted as being quite expensive. It does have a few differences between Vanco and metronidazole in terms of its spectrum. The first thing is that it's very narrow. So it really only has activity against Clostridial species. And so it doesn't have a lot of ancillary damage to the microbiome that we see with those other agents. The other thing is that it really, in the early studies that we saw come out, and this is why there really wasn't that much interest in fidaxomicin, was that there was no proven benefit from a mortality perspective with fidaxomicin compared to either Vanco or metronidazole. So people hadn't been so excited about it from that perspective. But I think the guidelines came out because there were many new clinical trials that were randomized looking at fidaxomicin versus Vanco that showed that perhaps mortality is not the most useful outcome in these patients. The risk of relapse for somebody who's treated for C. diff and gets better in 6 months is about 30%. That's pretty high. So, 1 in 3 of those patients is going to come back to the hospital with a relapse, despite getting sort of good therapy and a good response. So, the focus perhaps should be on reducing the risk of relapse. And that's where fidaxomicin comes in, right? I think the trials are really showing that fidaxomicin has a tremendously decreased risk of recurrence. The few randomized trials that were included in these new guidelines are showing that it's somewhere between 20 and 50% decreased risk of recurrence compared to vancomycin, which is pretty significant when you think about how many people have recurrence, right? 30%. The other thing about fidaxomicin, and this is probably more into the weeds, but fidaxomicin is bactericidal against Clostridial species, whereas vancomycin, metronidazole are bacteriostatic. So there may be both a benefit from a narrowness of the spectrum, but also from the mechanism of the agent in terms of it being sort of more effective from that perspective. And we think about that sometimes, when we choose antibiotics for other conditions. So I suspect that many people here have not used fidaxomicin for the treatment of C. diff. And I'll tell you, when I was a fellow in the States, when these guidelines came out, we immediately changed our practice, and that was driven very quickly by the quick uptake of insurance companies' willingness to pay for this drug. And the reason why they were so willing to pay for this drug is because even though it's very expensive from a upfront perspective, when you decrease the risk of relapse, you are greatly decreasing your overall healthcare cost. So if you're the payer, it's saving you money. And I think that in Canada, that's been a challenge. I think the sticker price is a stumbling point, but there have been many cost analyses which have shown that overall the benefit of using this drug is probably at a healthcare system level cost neutral, or potentially even slightly cost saving because of this reduction in relapse. So here you see basically what the new guidelines recommend. And the key emphasis here is that if you look at first episode, it's either preferred or acceptable alternative. That's how the wording is provided. So it's not that if you give vancomycin, it's not an acceptable drug or they're getting a substandard therapy, but there's evidence to suggest, obviously, from what I just told you, that fidaxomicin is preferred, but vanco would be acceptable. And what the guidelines say is we acknowledge the financial and health system constraints of providing access to this drug, and that it is not wildly superior. People are not dying more if they get vancomycin. So, it's something to consider. The other interesting thing is that you see in this sort of second column there, besletoxumab is listed. Besletoxumab is a monoclonal antibody to toxin B, which is secreted by particularly some of the more virulent NAP1 strains that make patients more sick with C. diff. It's a single infusion, and it's shown to also not alter mortality, but further decrease the risk of relapse on top of fidaxomicin. So it can, and depends on the studies you look at, but probably somewhere between 20 and 30% additional reduction in the risk of relapse. So in the guidelines, actually what they say is, if you come in with a first episode, it's either fidaxomicin or vancomycin, and it's 10 days. Which is different than what was written in the previous guidelines, which wrote something that was a little bit more vague. It said 10 to 14 days, your choice. Here, the guidelines say 10 days is enough. And then if you have risks for relapse, and the bar is pretty low here, you're over 65, you're immunocompromised, or you have one other risk factor, and these are minor things like being on a PPI, etc., then you should consider besletoxumab in addition to fidaxomicin or vanco. We don't have besletoxumab; it's not approved in Canada, but I think it's worth knowing because at some point it may arrive. If you have a first recurrence, it's the same sort of situation. There's a sort of alternative regimen of dosing the fidaxomicin, and then at the first recurrence, adjunctive treatment besletoxumab is recommended. And then, second or subsequent CDI recurrence, you can see here similar recommendations. And then most people are starting to think about FMT at this point, particularly if it's the second or particularly the third recurrence. You should definitely be thinking about FMT. On that note, FMT is on pause. So there isn't access to FMT at this moment. I talked to Dr. Abu Nasser about this, and I think they're planning to restart the FMT program in the beginning of the new year. but it's not entirely clear. FMT is actually on pause in the United States as well, and most people think this is COVID related, but it's never been an approved therapy in the United States. It's been offered under an EUA, which, like many things people are familiar with now, drugs that are sort of under investigation but haven't received their full approval. And the reason why it was revoked was actually because there were several bad outcomes that were reported to the FDA from Boston. And these were patients who were transplanted and had multi-drug resistant septic shock from pathogens that were transplanted through the fecal transplant. That happened just before COVID, and then they started finding COVID in the fecal donors, and the whole program and the EUA was revoked. And so there are downsides to FMT, and I think that we were really kind of just fascinated by the efficacy of this treatment and kind of the concept of this treatment, and I think it is a very good treatment. But I think that the screening processes and the standardization, particularly for centers who are doing their own FMT stool banking, is really variable, and I think there's some danger in that. I think the other issue is that as new diseases occur, like COVID, they're going to appear in your stool samples before you maybe have the ability to detect them. And you may be in a situation where you're transplanting stool with a pathogen that you're not aware of, that's going to cause infection to your patient and harm them instead of helping them. So we'll talk about some of the other things that are on the horizon. I think there's a lot of interest in alternatives to FMT because of these problems. But I'm just showing you this sort of to help people get up to date. A word more on fidaxomicin is that we can get access to it. I think if you're thinking about fidaxomicin, I think it would be very helpful or reasonable to call ID to get involved, because it's through the EAP process. It's special access through the government. They have specific criteria. They're not so generous at the moment, but there's some room there to help your patient. So we can help you with that. But it is available. So I think for people certainly who have had multiple recurrences, I think we should probably think about it, because that's where the benefit probably is. And I think if you're thinking in that direction, it might be helpful to get ID involved. The only other point I'll make here is that if you look at the recommendation for severe CDI, it is unchanged, and there's no mention of fidaxomicin there. So if it's severe, fidaxomicin has no evidence in that group yet, and I think that's just from a paucity of data. So building on the sort of idea that FMT has some downsides and is currently unavailable anyways, there have been a lot of people who have been interested in the concept of, restoration of the microbiome, and this being the problem with the rates of recurrence. There's this tremendous damage to your microbiome, which promotes the C. diff spores to kind of set you up for this chronic cycle of antibiotics and then relapse, antibiotics and then relapse. And so there's this very interesting agent. This paper was published just a couple of months ago or maybe a little more than that, maybe 6 months or so ago in the New England Journal. It's called SEER-109. It's an oral microbiome therapy, and it's targeted at restoration of the GI microbiome. So this study was a phase 3 randomized controlled trial in patients who were really not responding to treatment. So you had to have 3 or more episodes of CDI, so second recurrence or higher. And the product, which is called SEER-109, is purified vermiculite spores. This is from a small core group of fecal donors. And it's basically, vermiculites are a type of bacteria that occupy a lot of real estate in the bowel of most healthy people. And so they tried to purify these vermiculites, get rid of all the other bacteria and pathogens that might be in there with a sort of quite a robust purification process. And they used this SEER-109 versus placebo. The treatment was given after you got standard of care antibiotics for your C. diff. So you got fidaxomicin, vancomycin, and it was given for 3 days at the end of treatment. And the reason for that, again, is because this product is really trying to restore your gut microbiome. It's not an antimicrobial. And they looked at the primary outcome of risk recurrence at 8 weeks. You might think that's a little bit short, and it is, but here's what they found. So if you look at the left here at the graph, you can see how effective this was actually at restoring the microbiome and decreasing the risk of relapse. So the absolute or the relative risk reduction is 68%. So decreased by 68% the risk of a relapse in the first 8 weeks. And the reason why the follow-up period was only 8 weeks was because this was such interesting data that they decided to publish it. But just a couple of weeks ago, they published their 24-week data in the JAMA, in JAMA, and they showed that response was actually durable at 24 weeks. And if you look at the Kaplan-Meier curve, and it's a beautiful curve, you can see how early that benefit starts to manifest. You know, those curves are diverging very early on. As early as 2 weeks, you start to see a tremendous benefit of the restoration of your gut microbiome. And so I think these types of therapies are sort of FMT given in a really much more precise way, because I think FMT is doing a lot of what these sort of products are doing is putting the microbiome back into some kind of balance. But instead of giving sort of the whole microbiome of somebody else, you may be able to target some certain aspect of the microbiome, which may be the most effective. And this paper really has a nuanced discussion, because you think, well, why is this happening? You know, how is this vermiculite concoction, you know, so effective? And there's a really nuanced discussion about why they think that this is the case, and how they came up with vermiculites as opposed to any other number of bacteria in the microbiome. And it has to do with the balance of bile acid salts in the GI tract, and having high bile acid salts can be a sort of or produce a very formidable or happy environment for C. diff spores to continue to bloom. So controlling or decreasing that bile acid salt environment is an important part of reducing the risk for relapse, and that's what vermiculites do. They sort of have this huge role to play in the maintenance of a healthy bile acid balance in the GI tract. So takeaway messages from this, I think, are really that there's new guidelines. There's some nuances to them. I encourage you to read them, or at least look at the tables, which are really helpful. I think a couple of things to consider. One is that fidaxomicin is available by special access here. I think if you're thinking about it, call us. The second thing is, you know, remember, we used to say 10 to 14 days, but the guidelines are pretty clear that 10 days is enough for the vast majority of patients. And I think we're really at a new dawn in the era of microbiome therapy. And I think some of these more purified products are going to start to show tremendous efficacy. And I think this is probably where the direction of things is going, as opposed to sort of just whole FMT. And I think that's going to get around some of the challenges and the downsides of FMT that have started to show up. All right, so let's move on. So I wanted to talk about monkeypox as well. And I think the reason why I put this in my talk was because, you know, we get distracted by, or we've been very distracted by the pandemic. And I think, you know, there's other pandemics and outbreaks that have been overshadowed. And the WHO declared a monkeypox outbreak in July of 2022, which was not that long ago. And I think most people were just exhausted and too preoccupied to even care or want to even entertain the thought that there would be something else that they could have to, you know, be dealing with in the same way as COVID. But we certainly have had many cases in Hamilton. I've seen a bunch. So I think it's something we need to think about, because, you know, I think we've all come to realize that, you know, when we hear about these things in far off places, and this really first appeared in the UK and started to become of concern from a cluster of cases there, that these things are just a few hours away by plane, and it could be quickly at the doorstep of your hospital. And if you're not aware of it, then you may miss it. So I think just because I think a lot of people may not have a huge depth of knowledge around monkeypox, not expectedly, I was just going to summarize some of the basics here. But the basics is that it's an orthopox virus. Most people sort of remember that this is somehow related to smallpox, and it comes from the same genus. And smallpox is caused by a virus called variola. And that's had a vaccine for a very long time. Smallpox is the first and only disease that's ever been eradicated. So there are currently no smallpox cases in the world, and that's thanks to the most successful vaccine campaign ever rolled out. But monkeypox has been around for a long time, since the 70s, and it's tended to pop up here and there in both parts of West Africa and the Democratic Republic of the Congo. There's always been ongoing clusters of cases in these regions, but it's been relatively poorly understood over the years. It's not entirely clear what the reservoir is, but many studies have pointed to it being a few species of sort of small mammals and rodents, shrews, and rodents, squirrels in forested areas of Central and West Africa, though that's not 100% clear. But the main thing is that there's kind of these two clades of monkeypox, clade 1 and clade 2. And clade 1 is called, or traditionally has been called, the Congo clade, and clade 2 is the West African clade. The Congo clade is much more lethal. So the worry when this news emerged was that this could be the Congo clade. The mortality from the Congo clade can be up to 30%. The clade that ended up being, or so the derivative of the clade that ended up causing the current outbreak is actually the West African clade. It's much less severe. So outcomes from a mortality perspective, less than 1%. One thing I'll just say about the names, since we're talking about the clades, there's a huge advocacy push at this moment to actually rename monkeypox. I've put the actual interim names at the top. The preferred names is MPX virus or human monkeypox virus. Because there's been a tremendous amount of stigmatization. Many people feel like there are some racist undertones to this, and it frankly has nothing to do with monkeys. So it's a little bit confusing. And I've had many patients who've had monkeypox tell me that, you know, they just sort of feel kind of dirty, like they you know, this is something that they got from an animal or something like that, and so the name itself comes with a lot of stigma, and I think that's not a new concept, but I think people are coming to realize that the words we use to name diseases and what we call things is really important to patients, and can carry with it a lot of stigma or weight. So what's the current state of the outbreak? You certainly have heard about this, but like I said, there's been intermittent outbreaks, mostly in DRC and the west of Africa, but we've had outbreaks in other parts of the world intermittently over the years. The biggest one was in the Midwest in the early 2000s, but that was a big outbreak at the time, considered to be big outbreaks, about 30 cases. It happened as a result of importing what are they called? Prairie dogs from West Africa. The prairie dog is like Timon from the Lion King. So they are thought, or were thought, to be reservoirs, caused an outbreak because they were distributed as pets. The cases that were antecedent to the outbreak of late were picked up in the UK, and that was in May of this year, or May of 2022. They noticed that they had 11 cases, and when they did the epidemiologic tracing of these cases, 7 were travel-related. People came back from endemic regions, had monkeypox. That's nothing new, although it was a large cluster. But then they found 4 cases of people who presented to STI clinics who had no history of travel. And that's what triggered the alarm. That was very concerning, because that had really never been seen before. And there was really no epidemiological link to somebody who had been traveling, or the 7 index cases that had come from West Africa and DRC. So ultimately, from then till now, we've had 80,000 cases globally, and a majority of them have actually been in the United States, which is our closest neighbor, by the way. So 30,000 to date in the US. These are data from just a few days ago. What about here? So we certainly have seen our fair share of cases in Canada, but what I would point to is that this is a huge underestimate, right? For 2 reasons. One is most of these patients are too stigmatized or embarrassed to come and present to care. And 2, most clinicians, A, are not looking for this, and B, don't know how to do the testing for this. And so either diagnose a case of monkeypox, but don't do the testing, so it doesn't get reported to public health and counted in these numbers. So I think we have far more than the numbers of cases that are sitting in front of you on this slide. But regardless, Ontario and Quebec are the sort of #1 locations, not surprising from a population density perspective. In Ontario, as of about a week ago, we had 690 cases, but the case rate is dropping off, which is kind of good news. So what should we be looking for, and how does this present? I think there's classic monkeypox, which I'll kind of talk to you briefly about, and that's the clinical presentation of monkeypox that we've always thought about in endemic regions. And then there's sort of this version of monkeypox, which is related to the current outbreak. There's a great number of similarities and a few differences. I think the incubation traditionally is thought to be somewhere between 4 to 21 days, so pretty long. It's a little bit shorter based on the case investigation data that's been released from the CDC of a lot of the US cases, probably more in the range of 5 to 10 days, so shorter incubation period. Usually comes with a prodrome of a few days of fever, myalgias, fatigue, headache, and some lymphadenopathy. Non-specific, right? This could be COVID. This could be seroconversion HIV. Could be any number of things. They usually have the characteristic rash, and that's kind of what people are keeping their eyes out for. The rashes can be pruritic and painful, and they take quite a long time to resolve, about 2 to 4 weeks. The key thing, though, is that most people describe the rash as being vesicular, and that's sometimes true, but the rash actually comes in 5 stages, and these 5 stages are very different. So it can appear as a macule, sort of with just some erythema that's not raised, but then evolves into these sort of meaty papules, which can either have a little bit of vesiculation, but most often are sort of just these meaty papules with a central umbilication. And I think that's one of the distinguishing features. That could be confused with a few other diseases, but like molluscum. But this is something I think that's worth remembering. In terms of the clinical presentation, like I was saying, we won't spend a lot on this time on this, but classic monkeypox here down the middle, and comparing that to the outbreak as of now, they're pretty similar. The one thing I'll point to is that, and we don't have time to talk about this in depth, is that classic monkeypox is generally thought to be a zoonotic transmission. So it is being transmitted by contact with those small rodents, mammals, and transmitted to humans in that way, whereas that has not been documented at all in this outbreak. The outbreak has generally been among MSM networks, so men who have sex with men, though there have been cisgendered heterosexual women who have been positive, and certainly close contacts, family or household contacts of MSM men who have had monkeypox as well. The clinical features we talked about, the only thing I'll point to here is that different from classical monkeypox, some of these patients may come with lesions or symptoms very specific to the site of inoculation. And that's different than sort of the diffuse rash of monkeypox that would be classically described in endemic regions. So people may come with just pharyngitis, just proctitis, just a rash. The location of the lesions can be widespread or focal in the outbreak that we see now. So it's not like they have to have this sort of, varicella type chickenpox looking rash. It could be very focal to the genitals, or again, site of inoculation. And then the differential diagnosis is very wide. I think things to think about, STIs, hand, foot, and mouth, molluscum, bug bites, any viral exanthem. If you see patients with these types of rashes and you think of any of these things, I think you should also put monkeypox on that list. So what can we do about it? Well, there's a smallpox vaccine called Imvamune, and that has also gotten approval for monkeypox. It can be given as both pre-exposure prophylaxis, so not having been exposed to monkeypox or having had a contact, or post-exposure, so people who've had a contact and don't have a rash or don't have symptoms. Typically, that window of period of time for post-exposure is about 4 to 14 days, but I think it's anybody really who's coming and says I've had an exposure should be vaccinated. We won't go through the specific details of who the ministry is willing to give a vaccine to, but I think at this point it's really anybody who you think is at risk, And I would just point you to the direction of this place, which is where they can be vaccinated. So the key points to take away from this is that most people would be eligible for a vaccine if you think there's any risk. And I think this applies to, broadly speaking, MSM men. And there's a weekly sexual health clinic at the David Braley Health Science Center. That's that new building downtown. It's on the 3rd floor. They're open every Wednesday. And they'll vaccinate just about anybody who you send to them, both from a pre-exposure perspective and also from a post-exposure perspective. There is also antiviral therapy, something people may have heard about called TPOXX. Its formal name is tecovirimat. It's an oral antiviral. It was developed for smallpox. It's available in Canada through EAP access. So obviously, if you're thinking about any of this stuff, you're going to give us a call. Treatment is 14 days. We generally think about people who are immunocompromised with monkeypox. But the only thing I want you to take away from this part is that that's not the only group who, if you see have monkeypox, should potentially get an antiviral. So anybody with severe disease, so sepsis, encephalitis, involvement of the eyes, or generally sick enough with their lesions to require hospitalization, or has any level of necrosis related to their lesions, those people should get TPOXX. If they've got any lesions in an area that's at risk for serious sequelae, so scarring or strictures, so things involving the pharynx, the penile foreskin, generally sort of the GU tract where scarring and stricturing would be a concern, or that there's enough lesions that you'd think about secondary bacterial infection or they're on antibiotics. Those people also should be considered for TPOXX. The obvious people are people who are immunocompromised, but I think that goes without saying. So remember, these are some pictures of pretty common things we see: varicella, herpes labialis, syphilis, molluscum. You can see how these could be very easily called a monkeypox lesion. So I think, have a high degree of suspicion. It is around. If you're thinking about monkeypox, I think you should also think about other STIs as well and look for those. So the last part I wanted to talk about, because I want to leave some time for questions if possible, was just a few updates in Staph aureus bacteremia, and then a little bit about a trial that's coming to us here across the hospital sites in Hamilton. There's lots to talk about in Staph aureus bacteremia. This is a favorite topic of ID doctors, but I think one of the most interesting trials in Staph aureus bacteremia that's come out recently was this trial, which was published about April of this year. It was presented at the European ID conference and was called the Sabato Trial. And this was looking at uncomplicated Staph aureus bacteremia patients. And this is a minority of patients we see, right? These are patients who are hospitalized, but have, essentially uncomplicated disease or are low risk. And you can see what the trial design considered to be low risk. These are people who had follow-up blood cultures that were negative at 24 to 96 hours, so cleared very quickly, had no symptoms of metastatic infection after aggressive, investigation, and had their IV catheters removed very quickly, no prosthetic material, they were not immunocompromised. And the other thing I would add here, which wasn't part of the trial, was that you know where the source is, or you know what the source was. But this took these uncomplicated patients, randomized them to a 5 to 7 day lead-in of IV antibiotics, and this included MRSA and MSSA, and then looked at standard therapy, which would be 14 days of IV antibiotics, versus an early oral switch. They were looking at 90-day complication rate, which was relapse of bacteremia, a new deep-seated site of infection, or so endocarditis that we missed, or intra-abdominal abscess, or spinal osteo, or something like that. But also important secondary outcomes like length of stay, survival, and C. diff. And you can see here, they actually screened 5,331 patients and only enrolled 200. That speaks to the fact that these people are kind of like unicorns in our hospitals. We don't see them that often. It's very rare that we call somebody uncomplicated for the reasons that we mentioned, that the criteria are pretty, or the bar is pretty high. They didn't have a lot of MRSA patients, and the majority of these patients were basically the patients we tend to think of being uncomplicated. It's sort of the patient who has bacteremia under your nose from a catheter-related bloodstream infection or a sort of skin and soft tissue infection that rapidly improves. They used an oral switch mainly to Septra or trimethylsulfamethoxazole, but they also used alternatives, including clindamycin and linezolid for their respective MRSA or MSSA, based on susceptibility, of course. And this is what they found. They found that switch was non-inferior. So this kind of goes with a lot of the sort of data and ID for early oral switch. And so it was non-inferior for the early oral switch, according to them. Some of the secondary outcomes that are interesting is that they decrease length of stay by 4 days. So pretty helpful when thinking about transitions of care and sort of cost savings from a pressurized hospital system, which we're operating in. And there was no difference between 90-day mortality, no difference in terms of complications of IV therapy, and no increased rate of C. diff, or no difference in the rate of C. diff between the two, which none of those things are probably very surprising. So interesting, not something we do currently, but sort of interesting evidence for early oral switch in specifically uncomplicated patients. Remember, these are not the sort of complicated patients that we typically see, but maybe in selected patients, we may be safe to switch to oral therapy. But I think a lot of questions remain in Staph aureus bacteremia, particularly with those complex patients. And that's what I was going to talk to you about last, is that there's been a lot of interest in how to answer some of these questions. And there's been a new trial that's been launched out of Australia called the SNAP trial. And this is a network of researchers, Staph aureus Network Adaptive Platform, which is what SNAP stands for. And it's using a new type of trial design called an adaptive trial design, which basically kind of combines multiple questions into domains to try and get the most you can out of a set of patients that you enroll. Instead of enrolling patients in 6 separate trials to look at their intervention compared to a separate placebo group, they're trying to combine patients and use them sort of more sequentially to answer questions that have great clinical value. So we're going to be a site for SNAP, Hamilton Health Science, so Juravinski and Hamilton General, as well as St. Joe's. And this trial is probably going to get off the ground in the next couple of months, and we'll be looking to enroll patients. And I don't want to spend too much time talking about it. We don't have a ton of time left. But I just kind of want to give you the preview that this is coming. And we're basically looking for almost anybody who has Staph aureus bacteremia and is admitted to the hospital. It's pretty low bar to admission into the trial. So you just have to have one positive blood culture and be admitted. It will we have a coordinator who's helping us recruit these patients and look for these patients as well. So basically, if the patient's not interested in being in the trial, we'll still want to collect their data if they're agreeable into a registry, which we could do other things with. But it's going to have it's divided up into a bunch of domains. And as patients kind of go through their clinical course, they kind of flip from one domain to the next. And each domain has some kind of important clinical questions where the patient might be randomized to treatment versus not treatment, or one treatment versus treatment A versus treatment B. So the 3 main domains are an antibiotic backbone domain. So this is kind of like what the core treatment would be for the patient. Then an adjunctive treatment domain. That's looking at the benefit of clindamycin plus the backbone in outcomes for Staph aureus bacteremia, thinking about toxin production. And then the other one would be piggybacking on what I just showed you, which is early oral switch. So that's at day 7 or 14 based on clinical stability. This is kind of a busy slide, but it sort of gives you the overview of kind of how this type of adaptive trial design works. And if you go from the top, you're just kind of starting there at the inclusion criteria, basic criteria for our purposes, Staph aureus positive blood culture, admitted to hospital. And then the first randomization or first entry to treatment would be, are you eligible for adjunctive treatment? So you get randomized to clindamycin or not, plus your backbone therapy. And then once we have susceptibilities, then we sort of think about whether we give you focused treatment. And this basically is looking at, can we give penicillin if there's still a bunch of Staph aureus around that are penicillin susceptible? Could we just give people penicillin, or do we have to give them cefazolin or vancomycin, etc.? And there's a few other nuances to how patients will be randomized there, but that's the broad stroke concept. And then the last phase would be early PO switch. So at day 7, if you're uncomplicated, similar to Sabato, and then day 14 if you're complicated. So switch to oral versus continued IV. So I think this positive or negative will help us answer a lot of important questions that we've had over the years for Staph aureus bacteremia. So, we're hoping to be a leading site in enrolling patients, and we certainly have no shortage, as you all know, of Staph aureus bacteremia around. I won't spend too much time talking about the details of these domains. I think there will be more to come, but probably within the next month or so, we should be online as a clinical site, and we'll send you information about the trial, and reach out to me here at HGH, Leslie Martin at the Juravinski, and Zane Chagla, I think, is going to be the site lead at St. Joe's. Dominic Mertz is also sort of coordinating the whole of the 3 sites. So he's obviously a resource as well. So if you have questions about the trial, just keep an eye out for your email for information about this. But if you have questions in the meantime, just feel free to reach out to any of us about that. So we just have a last couple of minutes. I won't spend too much time on HIV, but the only thing I was going to tell you here is that there's going to be a huge shift in the next couple of years to long-acting injectable drugs. So I think from a GIM perspective, when you're thinking about people coming in, the old mantra is just don't stop their antiretroviral medication. You may start to see names you don't recognize anymore. And the patient will tell you they're not on pills, which might be really confusing. So I just want you to know that a lot of our patients, and we have some patients we've already switched over, a handful at the minute, but there'll be many more to come to long-acting injectable drugs, currently given once every 2 months. But better drugs are on the way, and we're probably in the next couple of years going to get to a Q6 monthly injection. And that I think will be revolutionary for many of our patients, but also something to keep an eye out when you're seeing these patients come through the general internal medicine service. So that's all I had. I appreciate the time. So I don't know if there's much time for questions, but happy to answer any. Stay online, call it if people want to ask questions.
Absolutely. Andrew, thank you so much. You've covered lots of good new stuff in ID that important to all of us. There are a couple of questions. I think the question from Leslie Martin about the fidaxomicin availability has been answered. So I'm going to jump into a question from Dr. Carnew, who's probably another grand round, is comment on shorter courses antibiotics in general. How long is needed? I think that's really good talk, but is there like a high level idea to approach?
Yeah, I think the general trend in ID is that less is more. I think we've been treating patients for most infections for far too long. I think UTIs are a good example of where people can really curtail some of their antibiotic use. Uncomplicated cystitis, 3 days isn't enough. I still would say 80% of the patients either I get referred or see treated for UTI, and this is uncomplicated, right? So mainly patients who are not in the hospital, don't have a catheter, are getting 5 to 7 days, or even sometimes 10 days of antibiotics. So I think cellulitis as well. I think if you treat the patient and you're on the shorter side of a range, you're probably okay. So if the range is 3 to 5, I think 3 is good. Pneumonia, 5 is good. VAP, 7 is good. So we don't need to convince ourselves that the patient needs more and more antibiotics. I think there's more and more studies that show that short courses is good enough.
Awesome. We'll take one more question. It's related to probiotics, and just a long question. It's comparing probiotics to the SER 106 that you've mentioned.
Yeah, I think so. Probiotics would be things that are perhaps either not major players in the gut microbiome, but I think the concept of probiotics and this sort of same concept of the gut restoration or restoration of the human GI tract is similar. I think the SER 109 is really focused on sort of biochemical restoration and restoring an environment that is unfavorable to C. diff relapse. And so probiotics are sort of, very general. There's a huge variation in the types of strains of bacteria that are in any given probiotic, and that's not very well regulated. And I think that's part of the problem with a lot of the studies, not showing much of a benefit. But I guess you could think about these purified vermiculites as a probiotic, but they're really just trying to replace a big gap that's been destroyed in your gut microbiome and try and restore some of the biochemical balance that helps keep your gut healthy, which is similar to what a probiotic is doing, but it is sort of a more precise approach, I suppose.
Fantastic. Andrew, you've shared a lot of new knowledge with us, and you've challenged us with the new approaches. I'm sure there'll be a lot of questions. I'm sure people can approach you directly with an email or question in the hallway like we always do. So sure. Thank you very much. And I know people have to be somewhere else, start taking care of patients and other meetings. So we appreciate your time this morning, and thank you for presenting great knowledge.
All right. Thanks, guys.
Thank you. Have a great day, everyone.